So we are going to begin our exploration of the female hormone world. And we're going to start with just an overview. I call this the female hormone primer. We're going to talk specifically about estrogen. That'll be next session. We'll talk specifically about progesterone and with an emphasis on post-hysterectomy, yay or nay. We'll talk about testosterone in women. And then we're going to sort of clean it up with some miscellaneous stuff, okay? So the female hormone primer, remember this at one time was a CME course, so we got to put all this stuff in. And so we're going to talk about pharmacology, physiology, functions of the major hormones that we're going to be talking about, bioidentical hormone replacement, or we're calling it optimization these days, I guess. That's the latest word. We'll talk a little bit about testosterone here because this is an overview, and then some of the things you're going to be seeing, discussing PCOS and some of the common things that we see. Okay. I don't know if I ever showed you this little slide before. So one of my acupuncture teachers way back when, Kiko Matsumoto was her name. She's actually very famous now in the acupuncture world, but at the time, no one had heard of her. And I found her at an acupuncture school in Stamford, Connecticut. And she would let me in on the weekends. I'd go there on Sundays. It was about a 3-hour drive from where I lived. I would go Sunday morning, and if I bought her lunch, and there was a Japanese restaurant down the street from where the school was, and she just ordered in Japanese. I never knew what the stuff was, but it was always really good. And she always said, this is what I want you to do right now is make pretend there's a zipper around your forehead. Unzip it, open your brain, turn yourself upside down, dump out all of your preconceived notions, then bring yourself right side up, zip your head back on, and then let's go. So that's kind of what that's what I want you to do. Okay. So I don't want you to think about everything causes cancer and everything is, and like you just mentioned, before we went on, that do what is in your training, and don't worry what anybody else says, which would be a nice sentiment. So we'll give you a couple of examples here to start with. This is menopausal Marie. Marie's 65 years old. She has a history of poorly controlled thyroid disease, hot flashes, night sweats, vaginal dryness, depression, poor libido, and fatigue, and she feels slow. So Marie was actually a real person, and she was my nurse, actually, 35 years ago. She was she weighs, I think she's about 4'8" or 4'10". She's short and stout, Italian, and opinionated. And I remembered her from 35 years ago, and she called me saying, and this is what she was complaining about. And I forgot that she was 35 years older because I can't imagine her being menopausal and having all of these kinds of symptoms. So past history of depression, high blood pressure, some sleep apnea, not on CPAP, hypothyroidism, which is in the family, urinary incontinence, some arthritis in her knee, and she was always a little bit pudgy, right? And apparently she'd had a gastric bypass. Family history: her dad was an alcoholic, which was kind of common back then, and both mom and dad had dementia. She's taking a baby aspirin, ginkgo. Remember, ginkgo is, in case, just to remind you, ginkgo is touted as a blood thinner. It actually, it's in its most potent form, it's the equivalent of 10% of a baby aspirin. So it's the equivalent of 8 milligrams of aspirin. So you need 10 full dosed ginkgos to get a total baby aspirin. So this is kind of like a redundant. Lexapro, levothyroxine, 137.5 milligrams, Prilosec, and I can never pronounce that one. I had a patient when this first came out called it Detrala. So Detrala. So she called it Detrala. So the long-acting 4 milligram for urinary incontinence. Here she is, blood pressure of 108/68, pulse of 80, temperature 98.7, 5'3". Okay. And 215 pounds, BMI of 37.41. So a little bit of hyporeflexic in the patellar and biceps. What would that tell you?
I mean, that would be an excess of thyroid hormone. That the hyperreflexia is
Right. Mm-hmm. Got it. Okay, very good. Eyebrows are nearly absent. Also thyroid, right? And some vaginal atrophy with some evidence of lichen sclerosis. So, it's pretty typical, I guess. We're focusing on the female hormones. That's why I highlighted them there. But as you can see, the testosterone levels are low. DHEA is low. Estrone, estradiol. Remember how we do that? The EP ratio was 420. PE ratio, the estradiol was basically 0. So really couldn't calculate that. And if you look over on the right-hand side, you see her thyroid antibodies are high also. And her TSH was 4.3 and her free T3 was 1.9. So you've seen these numbers before. We've actually discussed this one, and I've showed you the endocrinologist report before also. It's probably on here too. So then we have Julie. So Julie cysts have cysts. She's 37 years old. She has a history of a traumatic brain injury. She's got a lot of fatigue. She's got a short fuse. She's inattentive and has poor memory. She has a past history of an unspecified intracranial injury. She has fibrocystic disease, breast disease, also fatigue, a major depressive disorder, gastroparesis, irregular menses, heavy menses. She's had her gallbladder out, and headaches, mood swings, osteopenia, uterine fibroid, urinary urgency and frequency. Julie is 5'7". She weighs 258 pounds with a BMI of 40. Pressure is okay. O2 sat is okay. She's got some little scars from a lap chole and a gastric sleeve, and she has an 18-week size uterine fibroid. What do you want to do with her?
I have to think about that for a minute.
Yeah. Okay. She's on fluoxetine, so Prozac, and I can never pronounce that one. That's Abilify. Remember, use Abilify if the others don't work. Then life will be wonderful. She's also on what's that? Is that Percocets 10-33-25 and metoclopramide. Can you even get that anymore? I don't even think you can get that one anymore. Can you? Here's the workup that we did, pretty much our standard one. And she had an ultrasound of the pelvis. And here's Julie's labs here. And as you can see, her testosterone levels are high. Her estrogen progesterone ratio is really high. Did you ever see one this high?
No, I have not. Wow.
Do you do these calculations on your patients?
I do not routinely, but I will start doing them. Yeah, I do not.
I've been hitting my head over for giving you these great little tools for over a year, and you don't use them. You should be ashamed of yourself.
I am. I'm sorry, sir. Yeah, I do them on difficult, complex cases because what you've taught me is so incredibly valuable. Some of the rote, straightforward cases, it's just laziness. I need to do it every patient.
I give you a hint. I do it on everyone every time. Yeah. So that way you don't miss anything. Usually by the time they get to us, they've already been to 3 doctors, right? And a psychologist and an iridologist and a Reiki master and they went to the ashram in India, right? and the one who's got it nailed is their cousin's sister, who's the wife of an optometrist in Kokomo, Indiana. They're the one, right? Does that sound familiar?
That is so funny. All these stories sound the same from these patients. It's like they all talk to each other.
Yeah, I know. So I don't know, where you live, but so Reno, as you know, is a bit smaller town than Dallas area. So they got a Facebook page here it's called South Reno Moms, and apparently I'm the talk. I'm a hot topic in South Reno Moms. I tried looking at it. I tried looking it up once, but it's a closed group, and you have to ask to join. And I didn't know if I would qualify, so I didn't bother.
Great.
CRP is 5.71. Remember, normal is 0 to 3. Our goal is less than 1. Our vitamin D was 17. Homocysteine was 10.8. Our goal is less than 10. And our IGF-1 was 128. So we got a lot of juicy stuff here with Julie, right? She's going to go home with a bag full of stuff. Okay. So why fool around with hormones, right? I mean, why bother at all? Didn't we hear it causes cancer? We should never use them, right? Isn't that the perception out there? Is it getting better or not? I don't really know. So anyway, short-term symptom relief, long-term hormonal effects, protects the bones, memory, heart, and even breast protection, believe it or not. So physical signs of aging, so hair loss. Female pattern hair loss is hair that's lost not at the hairline, but inside the hairline. It's sort of like if you would take like almost like a beanie and put it on top of their head and draw a circle around it, and then take the beanie off. That's where the hair loss is in female hair loss, as opposed to male pattern hair loss. Dry eyes, pale face, sagging face, dry skin. Just sort of looking all washed out. Symptom relief, and we go through these, with each hormone specifically, but hot flashes, night sweats, brain fog, belly fat, memory loss, agitated, irritable, can't sleep, poor libido, headaches, short-tempered, anxiety, depression, poor sense of self-worth, poor muscle tone, urinary incontinence, vaginal dryness, poor libido. For guys, erectile dysfunction. Blood sugars are inversely related to the testosterone levels in men and women. When you wake up in the morning, are they tired? Do they need something to keep them going in midday? Are they tired in the afternoon? Do they fall asleep by dinner time, but then get a second wind later at night? Dry skin, dry hair, fingernails crack and break, constipation, can't lose weight, cold all the time, tired all day long, memory loss. How was that? That was pretty good, wasn't it?
Yes.
I didn't read from the slides. Okay. Here's your lineup, and this is what we look at: estrogens, progesterones, testosterone, sex hormone binding globulin, thyroid, cortisol, pregnenolone, insulin, and there's two more. Growth hormone is missing here, and prolactin. Okay. I've showed you this, many times. You should know this by heart by now. I don't mean all the these little things here, but you should know this cascade by now, right? You got this, right?
Yes, sir.
Okay. So we're going to start with estrogen. It's the major female sex hormone. It's produced in the ovaries, in the placenta when pregnant, adrenal glands, breast, and fat cells. Okay, and the majority during the cycling years is in the ovaries. It's in the adrenal glands and fat cells in postmenopausal, and it changes the nature of the dominant estrogen. The hypothalamus stimulates the anterior pituitary via the FSH to stimulate the ovaries particularly the thecal cells and the granulosa cells to produce estrogen. Estrogen has 400 functions, and I'm not going to go through all of them, but the ones in blue are the major ones. Increased metabolic rate, increased insulin sensitivity, it improves sleep, it dilates small arteries, increases blood flow, particularly to the brain. And, we discuss over and over again, especially in men, having enough estrogen to maintain cerebral circulation. You remember early on when we first started doing this, we would get guys testosterone levels to 1,500 total, and then we would give them estrogen blockers to get it to 0. And, we caused all sorts of problems with that. It decreases the accumulation of plaque on the arteries, and it maintains the amount of collagen in the skin. Decreases blood pressure. It decreases the bad cholesterol. It helps maintain memory, increases reasoning. It reduces overall risk of heart disease by up to 40 to 50%. It acts that's versus low or low the lower third or lower quartile of estrogen patients. It acts as a natural calcium channel blocker, enhances memory, mood, concentration, bone density, and it mimics antipsychotic medications. And there's a theory that particularly schizophrenia is a loss of estrogen in the cerebral circulation. It aids in the formation of neurotransmitters, again, such as serotonin, and decreases depression, irritability, anxiety, and pain. Preserves bones. That's a big one, especially in osteoporosis. It reduces homocysteine, and it reduces wrinkles. You do nursing home stuff?
With about 15 nursing homes. Yes, big one.
So you go to the nursing homes and you go to the lunchroom there where they're all sitting around, eating and whatever it is they do there, mostly sleeping. And take a look at the ladies. Look at their skin, especially the zygomatic arch, where we put the fillers, and you'll see the ones that have really smooth skin and they're sitting up and they're alert. They've had hormone treatment, even the synthetics, at some point in their life. And the ones that are all slumped over and have osteoporosis and their skin's all wrinkled up and they're still breathing, but they're not really alive. Those are the ones that did not. You can pick them out. Right. So the next time you go there, just don't even say anything. Just look around. Just look at them, and you can pick them out. You'll see it. Estrogen deficiency is hot flashes, night sweats, brain fog, belly fat, memory loss, irregular menstrual cycles, no menstrual cycles, thinning skin, wrinkles around the mouth. So you see, especially in within the first 10 years of menopause onset, the women get wrinkles around the mouth. We do a lot of cosmetic stuff for that. And so it comes from two things. One is smoking, and the other is loss of estrogen. Those are basically your two reasons: osteoporosis, diabetes, elevated LDL, heart disease. This was that vertex, what I was trying to describe before. This is where you get the hair loss here for females with estrogen deficiency, as opposed to the hairline, the scalp and the hairline itself. So you get hair that's kind of preserved here, but the hair's gone here. And again, wrinkles, dry eyes, shallow faces. You get thinning of the lips, and you get those vertical lines above the lip also. Almost like they've been sucking on a straw for years and years. This is a gal who was beginning menopause. You see, she looks pretty. Skin looks pretty smooth, but you can see over on the right, she's a lot better. This was 6 months later with estrogen replacement. You see the hair's thicker. Her skin, her cheeks are smoother, and she's got more volume in her face. Okay, the chin is a bit rounder. Okay, estrogen will reverse skin and muscle aging. You'll get increased skin and muscle mucosa volume and increased muscle volume, decreased fat mass. Fat and lean mass during estrogen therapy, as you can see down, especially at the bottom there, the lean muscle mass is improved by almost double with adequate testosterone therapy, or sorry, estrogen therapy. This is for 2 years. With transdermal estradiol is way better than the oral, as you can see here. Okay, you get actually an increase in fat mass with the oral estradiol, not as much as with none, but you get a fat loss with the transdermal and increased lean mass. Okay, so another reason, a reminder, that we use other than blood clots. for transdermal. Transdermal estradiol prevents heart attacks. Here's heart attacks, the number of heart attacks sort of being neutral just down the line here. Here is your estrogen patch. Here is your vaginal gel. And here is, these are your estrogen and progestin pills. And estrogen pills, you know, pretty much no change. So you can see here again, the transdermal and vaginal estrogens are much more beneficial than the pill form. And of course, never synthetics, right? You know that, right? Estrogen excess. So too much estrogen is an inflammatory state, and estrogen will form cysts. And the target organs, the breast, the uterus, and the ovaries, are the areas where it goes. Breast tenderness, breast swelling, fibrocystic breast disease, uterine fibroids, ovarian cysts, endometriosis. They're all the same, okay? It's all the same. It's just the tissue that we're talking about. And you're going to find it with elevated estrone, the bad guy estrogen, and gallstones. So not infrequently, remember that the patient that I showed you, she already had her gallbladder out, and she was basically estrogen dominant, right? If you remember that, we'll go over her again. All right, but you'll see this over and over again. If you ask them if they had a mammogram, and if they did, invariably they're going to tell you it said, I have dense breasts. That's what the mammogram is going to show. Okay. So a lot of times, I think you've seen me do this, right? Have you seen me do this with the patient? I'll tell them, let me tell you what your mammogram shows. I haven't seen it. I've never laid eyes on you, besides 10 minutes ago. Your mammogram says you have dense breasts. And that really builds confidence. How would he know that? Go ask a gynecologist. They have no clue. Ask them, go. Do it. Do it, right? They have no clue, right? Weight gain, menstrual bleeding, spotting between periods. So these are the gals. They get pellets and they get estrogen, and they either have inadequate progesterone balancing or they get none, and then they have they all of a sudden they get menstrual bleeding. So that's what you're going to find here. Okay, memory loss. With deficiency, and you're going to get breast enlargement, breast tenderness. You can also get prostate enlargement, your difficulty urinating, and then emotional liability. This is for men, okay? And tearfulness. So in other words, they're kind of whining like girls. And the symptoms are the same for guys, I don't think I have estrogen in men. I should get rid of excess menstrual bleeding there, but you can get headaches, breast tenderness, gynecomastia, bloating, anxiety, fear, fatigue, hypothyroid symptoms, fluid retention. So pretty much the same thing. And then, of course, there's cancer. This is the elephant in the room. Did I tell you what this was? We talked about, this is Lucy the elephant.
Yes.
Right. This was a hotel that was built in 1881 in South Atlantic City, New Jersey. It's still there. They moved it down a couple towns down the Margate. It was restored. It's now a museum. The eyes here, you can go in here. It's a museum in here. You can go up on the top here, the how do. You can see the ocean's to the right and the city of Margate, New Jersey is to the left. And you can look through the eyes also. So
the inside was actually a hotel.
It was a hotel. Yeah. That's what it was. Yeah. It was called the Elephant Hotel. So, they don't do stuff like that anymore. So. Okay. The WHI study, I think we beat this one to death, right? Yeah, you know all about this, right? So they use Premarin and Prempro. They use synthetic estrogen, synthetic progesterone, and synthetic combinations. And, it was a big disaster. Premarin alone, given to older postmenopausal females, caused adverse effects in the first year, strokes and blood clots. The transdermal estradiols, as we've shown you before, does not. Adding in Provera or Prempro, which is a combination of Premarin and Provera, was even worse. It was a 50% increase or 40% increase versus baseline patients who did not have hormones of breast cancers, heart attacks, and strokes. This was, highly inflammatory. The problem is that the stuff's made from horse urine, and we're not horses, right? You remember what the FDA said about ivermectin? Come on, y'all, you're not a horse, right? Hormones related to cancers occur after age 50. So if estrogens and progesterones cause cancer, why don't young girls, for the most part, get cancers? They're the ones who have lots of estrogen and progesterone. The more mature females after 50 don't have it anymore. So again, it's kind of the same thinking with the testosterone causes prostate cancer in men. Well, then how come 20-year-olds don't get prostate cancer?
That's right.
Right. So, so this is just, okay. Sorry about that. So this is just kind of just the chemical composition. This is estrone, which is the E1. This is actually the bad guy. This is the cancer causing one. And the point here is that this is estrone, and these are the horse urines, and you can see they're not the same. Okay, and I mean, this is a big problem. There's equine estrogens have 10 types of estrogen in it. Only 3 of them are human, and these are chemicals. Okay, this is a hormone. These are chemicals. We don't want to use chemicals. Our bodies don't like it. Natural estrogen is defined as the same chemical structure that the patient is born with. Natural estrogen helps to protect against endothelial dysfunction. It increases blood flow to the brain. It protects against heart disease, dementia, osteoporosis, and improves insulin sensitivity. Estrogens are, again, here are the 3 types of estrogen: estrone, estradiol, estriol, and they're the 2 most popular synthetic ones over on the right. And again, you can see that they're not the same. Natural estrogens do what estrogen is supposed to do. So natural is chemically the same as we make naturally. So it will eliminate hot flashes, night sweats. It maintains skin thickness. It will maintain hair. It maintains pelvic health, and it protects against colon cancers and macular degeneration. And again, the transdermal estradiols will decrease or neutral risk of blood clots. And as we saw, fat accumulation. The oral estradiols, even the natural ones, have about a 4 to 5 times increased incidence of blood clots, and about double the risk of increasing fat. Natural estrogens decrease the risk of diabetes mellitus, and it widens the internal carotid artery lumens by up to 224% when administered over 6 months. So again, blood flow to the brain. Synthetic estrogens increase blood pressure and triglycerides and increase the risk of breast cancer by 8 cases per year, per 10,000 per year. This was the EPIC study. This was done 5 years after the WHI, and this study had 55,000 women in it. It had an arm with patients who had no hormones. This was synthetic Premarin, again, synthetic estrogen. This is synthetic Premarin and Provera, so the Prempro, and this is natural estrogen and progesterone. And so the synthetic estrogen this is baseline, about 10 cancers per 100,000 women years, person years, however they calculate it. On average, the synthetic Premarin had 20% higher incidence of cancers than no hormones at all. The Prempro had 40%. That's from baseline, from no hormones at all. And this is the natural estrogen, natural progesterone, and they had 10% less cancers than if we gave them nothing. 50% less cancers if we gave versus the synthetic estrogen progesterones, and 30% less than if we gave them just Premarin. So you can see here actually natural estrogen, natural progesterone is actually safer than if we give them nothing. Okay, this was a 55,000 women. This was done over 8 years, and it was done. This was done in Europe. 23,000 women treated with natural biased estrogen, progesterone, estradiol, estriol. There was a decrease in mortality of 28% from breast cancer and 23% in all-cause mortality over 10 years with the natural estrogens. This was a 10-year, or actually 11 years post breast cancer survival rate. And this was the patients weren't giving any hormones at all. This was the mortality rate. 33% of those patients were gone within 11 years after breast cancer episode. Those that were given progesterone and testosterone, 87%, 7 out of 8 were still alive. Those that were given natural estrogen, natural progesterone, natural testosterone, 94% of them were still with us 11 years later. So this notion that if we give them estrogens, we're going to kill them is actually kind of upside down. So, and you'll see that they're tiptoeing back, giving them a little bit of estradiol 2 years post chemotherapy. That seems to be the consensus around here. So natural estrogen, there's 3 types, 1, 2, and 3. Estrone, E-S-T-R-O-N-E, 1. 2, estradiol, di-2, estriol, 3. Again, here's the steroidogenic pathway. So estrone actually comes from, remember, everything starts with cholesterol, and it can go converts to pregnenolone, to progesterone, to 17-hydroxyprogesterone, to androstenedione, or this way, 17-hydroxypregnenolone, to DHEA, to androstenedione, to esterone. This is the bad guy. And we measure this one on everybody. We want a level, and I don't remember the units. We want it less than 100. Okay, and usually anything over 90 will intervene. So that's the bad guy. Estradiol comes mostly from conversion of testosterone, aromatase conversion from testosterone, and the estriol actually comes from the estrone also. So 3 different types of estrogens. Estrone, remember, this is the bad guy. This is the one the body makes postmenopausal. So your postmenopausal patients, you'll get an estradiol level of 12 and an estrone level of 80. Okay, it's produced in the adrenal glands and fat tissue, and this increases the risk of breast cancer. Estrone increases the risk of heart attacks, strokes, breast cancer, prostate cancer, acne. It's thrombogenic. Its breakdown products are the 2-hydroxy. Remember, the estrogens are the 2-hydroxy estrone and the 4-hydroxy and 16-hydroxy estrones. So the 2-hydroxy is the pathway we want our estrogens to go down, and the 4 and the 16 are the ones we want to try to avoid. Estrone is the one that causes too much estrone, causes gallstones. It increases liver enzymes. It will increase sex hormone binding globulin, which, remember, has an affinity for testosterone more than estrogen. And so it will actually decrease testosterone levels. It will interrupt the tryptophan sequence and consequently decrease serotonin. It leads to brain fog, depression. It will lower growth hormone. It increases blood clots. It increases C-reactive protein, and it increases carbohydrate cravings. We use 7-keto DHEA as our remedy here, and this works quite nicely. It's pretty reliable. I usually start at 25 milligrams at bedtime. You can go up to 100. I rarely have to go more than 50. And on average, in about 4 to 6 weeks, it will decrease your estrone levels by 50%. So it's pretty effective. It's pretty benign. It actually has a side effect, if you want to call it that. It was actually touted by Dr. Oz many years ago on his TV show for weight loss. So if you think about it, if it lowers estrone, estrone is the it increases belly fat, and so the 7-keto DHEA lowers estrone, and the patients will lose weight. So I'm not sure how potent it is. We don't really use it for weight loss, but it is. You just keep it in the back of your mind. If they have a high estrone level, that you should see at least a stabilization of weight, or maybe even a little bit of weight loss. If you're not doing anything else. Estradiol increases your good cholesterol, HDL, decreases LDL, decreases triglycerides. It helps maintain bone structure. Let's go back to this for a minute. Remember I told you about the guy who lectures at A4M and takes the male takes 7 or 8 milligrams of estradiol a day. And he says this is the way to raise HDL cholesterol is to treat your patients with estrogens. So we talked about him, right? So it's a little bit crazy to me. Remember, he gets his male testosterone levels up to 2,000, and he lets the estradiols run, and he says he likes it to see between 150 and 175, which is crazy to me, but I don't know. You've been doing this for a while. I mean, patients have estradiol levels that are over in the 50s and 60s. Don't they have all sorts of, erectile dysfunctions and depressions? And the guys I'm talking about, right? I mean, that's what I see. We get it down under 40 and they do a lot better. So, but, far be it for me to say any better. Again, estradiol will increase serotonin. It's an antidepressant. It works as an antioxidant. And it helps absorb calcium, magnesium, and zinc. Estriol is 80 times weaker than estradiol. That's when we do our bias. We usually do it in about a 3-to-1 ratio or a 4-to-1 ratio of estriol to estradiol. It's much less stimulatory. It protects against breast cancer. It's actually the pelvic estrogen. In young patients, it gets the pelvis ready to be able to be embedded, for conception. And in more mature patients, I shouldn't say older, more mature patients, it keeps the pelvis lubricated. There's no effect on the bone, heart, or brain. It maintains pregnancy, the vaginal lining. It occupies estrogen receptor sites in breast tissue, and it blocks the estrone. It controls menopausal symptoms and increases HDL and lowers LDL. It reduces pathogenic bacteria and maintains vaginal pH, prevents urinary infections, and it aids in GI tract maintenance for the microbiome. Estrogen receptors, alpha, there's alphas and betas. Alphas increase cell growth, betas decrease cell growth. Estrone activates estrogen receptor alpha selectively in a ratio of about 5-to-1. This results in cell proliferation. Estradiol activates estrogen receptor 2, and estriol binds estrogen receptor beta in a 3-to-1 ratio, so that aids, again, it displaces estriol, and it goes into the estrogen beta receptors. Your two major pathways, 2-hydroxy, 16-hydroxy estrone are your major ones, and 4-hydroxy is your minor one. Here it is in that cascade again. So here's your 16, and here's your 4, and here's your 2s. Okay. The 2-hydroxy methylation pathway. This is your good estrogen. It does not stimulate cell growth. It blocks carcinogenic estrogen products. It protects against cancer, and it improves methylation ability. You can look at homocysteine as a sort of a marker for that. If you don't want to do any of these fancier ones, they're they get to be a little bit messy. I have no idea. I've never ever ordered any of these, so I don't know if you have, but. So raising 2-hydroxy estrone levels, again, the good stuff. So exercise, cruciferous vegetables. Remember, be careful with those with thyroid disease. Soy, kudzu, flaxseed oil, broccoli derivatives. So your indole-3 carbanols, your DIMs, and your sulforaphanes. omega-3 fatty acids, methylated B vitamins, TMG, that's betaine, hydrochloric acid, rosemary, turmeric, and high protein diet. 2-hydroxyestrone, you can use homocysteine as a proxy for methylation for measuring this. Our goal is less than 10, and it will you'll get lower ratios of the 2 to 16 hydroxyestrone levels in lupus. Methylation support, so stress reduction, SAMe, methionine, methylated B vitamins. We're not doing CMEs. I like Apex's methyl SP, and they have a super methyl SP. Those are the ones I use. Pretty much every company makes a combination here, methylated one. So whatever one you like. TMG betaine, that's part of Dr. McCullough's spike detox formula now. You know what that is?
No.
Curcumin, 500 milligrams twice a day. Make sure it has black pepper in it. Betaine, 500 milligrams once a day, and nattokinase, 100 milligrams twice a day. And that's a long COVID, to get rid of the spike protein.
Really?
There you go.
Men and women.
Yep. Mm-hmm.
And that's something that Marcola put together?
It was Dr. McCullough, yeah. And we've been using that, those things all along. I don't know, it's that big a revelation, but he's been putting it out there as a combination. I think he's formulated one pill that has all three in it. So we'll see. I get them separate. 16-hydroxy estrone. And again, you can get these. I think the Dutch test will give you these levels. This is the high estrogenic, breast cancer, obesity. This is where you're going to get your estrogen excess symptoms. Your endocrine disruptors here, pesticides, and you'll get elevated inflammatory cytokines, omega-3 fatty acid excess. The 4-hydroxy directly damages DNA, enhances cancer. So, we want you to go down the 2-hydroxy estrogen pathway, not these other two. So these are the things we talked about. Just going back here again to reiterate these things here. So cruciferous vegetables, flaxseed oil, soy, kudzu, broccoli derivatives, sulforaphane. By the way, sulforaphane will enhance dihydrotestosterone. So for females with hair loss, sulforaphane is actually not a bad way to go. Omega-3 fatty acids, MTHFR, methylated B vitamins, rosemary and turmeric, weight loss, TMG. Okay. So I just went back just to reiterate that. Increased 4-hydroxyestrone is in the presence of methionine, folic acid deficiency, uterine fibroids, also probably B12. Okay. Your equine estrogen. So this is your synthetic estrogens, your Premarins, metabolize into the 4-hydroxyestrone world. Those that are obese, a decreased 2-hydroxy to 16-hydroxy estrone ratio. Your xenoestrogens, your endocrine disruptors will increase will decrease this ratio. Alcohol, the bad stuff, alcohol, antibiotics, a disruption in the microbiome from leaky gut causes inflammation, and you'll get this also. Estrogen in the brain. So estrogen increases blood flow, oxygen, and blood sugars, neurotransmitter quantity and function, sensitivity to nerve-derived growth factor, manual dexterity and speed, the availability of acetylcholine, and long-term memory. It decreases amyloid peptides and plaques and distractibility. I must have no estrogen then because I'm distracted all the time. It protects neurons, keeps the blood-brain barrier intact as a natural antioxidant, and it signals progesterone receptors. Estradiol's properties, I mentioned this just a little while ago, similar to atypical antipsychotics medications, and it influences dopamine, serotonin, and glutamine. And there's a theory out. I know I'm sure the psychiatrists don't know anything about it, but that particularly schizophrenia is a deficiency in estradiol, particularly in the frontal lobe. Cognition, estradiol, testosterone, and IGF-1 are independent and selective effects on cognition. 17-alpha estradiol is found to be neuroprotective after a stroke or TBI or in Alzheimer's disease, and it influences spatial memory and hippocampal-dependent synaptic plasticity. In other words, you have somebody with neurodegenerative issues, you need to look at their hormones, okay? They need to be balanced. You don't get you don't get a miracle overnight, but over 3 to 6 months, you're going to see a significant improvement versus leaving them alone. Probably you'll increase their recovery time by approximately a year. I have a special lecture on neurocognitive decline and the hormones. So that's in that one. Pre-existing low estrogen levels, i.e. postmenopausal women and I guess young girls, girls, before puberty, are susceptible to developing PTSD. High estrogen levels are protective. Estrogen lowers the risk of PTSD after trauma, modulates pain, and CFS estradiol is lower after traumatic brain injuries. Estrogen maintains blood flow to the brain. We already talked about this. It prevents apoptosis, cell death, and acts like a growth factor. It increases under stressful conditions such as critical illness and trauma. It decreases the risk and progression of neurological deterioration, particularly Alzheimer's disease, schizophrenia, and it aids in the recovery from strokes and TBI. It prevents neuronal loss in the central nervous system. Estrogen and progestin replacement after carotid looking at the carotid artery, and what you'll see is carotid wall thickness, so narrower arteries will regress, so the lumen will improve quite a bit with adequate estrogen and progesterone levels. That's what we're showing you here, okay? This is estrogen alone. This is estrogen with progestin, again, synthetic. When you see progestin, that means synthetic progesterone. So we really don't even want to see these kinds of studies because they're kind of useless to us. Laboratory studies, as you know, we like the lab values to be in the mid-range to the upper third of the normal value. And we look at those normals and optimals. We've gone over these before. These slides, I don't know if you already have these. These will give you the median ranges of the lab values. This is risk factors. So premenopausal estradiol levels. We usually draw levels in patients that are still having menstrual cycles on days 19 through 21. That's where you get that peak of progesterone and you get the second peak of estrogen. And so you get that ratio there. That's probably the ideal when you're doing serum levels. And here are some, common maladies that adequate estrogen will, help relieve. And we have premenopausal normal lab values. You can get osteoporosis is common. This is on day 7 of the cycle, and lower than 97. You get heart disease, bone deterioration, and then postmenopausal. Most of the labs around here anyway say normal estradiol is less than 54. You get psychosis, postpartum depression, and ischemic heart disease. So again, I don't really pay attention to what the normal lab values are. If you'll remember, we do the ratio of estrogens to progesterone. We do an estrone plus estradiol divided by progesterone. Our goal there is less than 250. Here's the workup. You should know. You should have this by now. As you know, I've sort of almost eliminated the 4-point saliva test. It's kind of expensive, and I rely on the reverse T3. if we don't getting anywhere with the reverse T3, then we'll do that 4-point saliva test. Progesterone is the dominant hormone in the second half of the cycle. It's our political operative. It's the cleanup crew. Estrogen goes out there and says you're a no good so and so, and you're all deplorables out there, and you're irredeemable. And then progesterone is the press secretary saying, nah, she didn't say that. Nah, he didn't mean that. That's progesterone. Progesterone's the cleanup crew. The mess, estrogen makes the mess. And the messes we talked about are things like headaches, breast tenderness, cysts, breast, uterine, ovary cysts, cancers, fibroids, gallstones, moodiness, abdominal pain, PMS. Progesterone's the cleanup crew. I liken it to Ralph Cramden. You remember the Honeymooners? Ralph would get himself in trouble, and Alice would scold him, and he'd go hamina, 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 and then he'd shake his hand and whatnot, and then at the end they'd kiss and make up. Alice would get him out of trouble. So natural progesterone maintains pregnancy. It improves mood. It improves sleep. It's a diuretic. There's no effects on blood sugar. There's no evidence of cardiovascular disease. It decreases breast stimulation, prevents breast cancer. The synthetics do the opposite. They are depressive. They cause insomnia, fluid retention. They raise blood sugar. They worsen the lipid profiles. They can cause heart attacks. They increase breast stimulation and can cause breast cancer. Side effects of progestins not seen in progesterone are all of these. Again, weight gain, fluid retention, irritability, depression, headaches, bloating, breast tenderness, acne, hair loss, interferes with the body's own progesterone production. It does not balance estrogens. It can cause spasm of the coronary arteries. Again, here's the chemical composition. On the left is progesterone, and on the right are synthetic estrogens. And again, the point of this is they're not the same. There's a lot of literature they'll just call it progestin and not make the distinction between progesterone and the synthetics. And for the longest time, I think we're getting away from it finally, but for the longest time, the Endocrine Society, the OBGYN societies, they all said it didn't matter what the chemical composition was, it was all the same. So we know that's not true, right? But for the longest time, they said that. Progesterone balances estrogen, improves sleep, has natural calming effect, lowers blood pressures, helps the body use and eliminate fats, and it lowers cholesterol. Increases scalp hair, balances fluids. It's a natural diuretic. It's a natural antidepressant. It's anti-inflammatory. Remember, progesterone is sedating. When we use it at bedtime, and it helps sleep. Stimulates bone production, enhances thyroid function, improves libido, increases oxygenation. It promotes Th2 immunity. Dr. Halassa will like that. It does not induce estrogen-stimulated breast proliferation. Here's that study again, the EPIC study, showing you natural estrogen, natural progesterone have less cancer risk than if we gave you nothing, and much less if we gave you the synthetics. This was a study that looked at progesterone levels versus breast cancer. When the progesterone levels were less than 9 nanograms per milliliter, there was no change in breast cancer risk. When it was between 9 and 13.54, which is pretty high, there was a decreased risk of breast cancer of 60%. And when it was over 13.5, it was a decreased breast cancer risk of 88%. So progesterone is your friend. And, we'll do a whole 30 minutes on progesterone after hysterectomy, as we know that, it's quite necessary. There's a theory that the breast cancers come not from high estrogens, but low progesterone. I mean, remember the ratio, it's the relative risk factor. These are over 700 patients were followed for over 30 years with diagnoses of infertility, luteal phase defect, and progesterone deficiency. There was 10 times the risk of death from all cancers and 5.5 times the risk of breast cancer in premenopausal patients with these luteal phase defects and progesterone deficiencies. So it looks like low progesterone is the culprit here. Okay. And then so our bottom line, never, ever, 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 ever use estrogen without progesterone, ever. And if patients don't want progesterone, and if my doctor said they don't need progesterone, don't use it. Okay. Go with Serenol, which is a, if you have to, which is that Swedish bee pollen from Bonafide. That works pretty well. That covers your progesterone symptoms. We went over all of those before. We'll look at them again. Relazin is the Swedish bee pollen for estrogenic properties, also from Bonafide. They used to have a rep before the shutdown. There was a rep used to come by and would give us samples, and we could put them in our office, but we can't do that now. We don't get it, so you have to get them online, either from the company or it's on Amazon. They're a little expensive. They're about $70 a month. Yeah, it's a little expensive, but they absolutely work. They work like a charm. Whatever affects you're trying to affect with estrogen, Relazin works to a T, and whatever effects that you want from progesterone, the Serenol works to a T. I mean, they absolutely work. There's other things, as you know, you can use black cohosh and chasteberry. There's combinations. We do use those a lot. They're a lot less expensive and a lot easier to obtain. We have those in the office. And some of those other things that we talked about, the sulforaphanes and whatnot. So the estrogen progesterone balance, that's our key. Estrogen, adequate estrogen, you got good mood, good energy. Progesterone is calming, and when you have loss of either, you get fatigue, depression, menstrual headaches, poor libido. So when your patients complain of premenstrual syndrome, you need to ask them, are the symptoms during menses or prior? So if it's the week prior to menses, that's a progesterone deficiency. If it's during menses, that's an estrogen deficiency. And so then adjust accordingly. Okay. But that's a little tip there. This happens a lot. They'll say, I got PMS. So you have got to ask them again, is it before your period or during your period? If it's before the period, it's progesterone. If it's during the period, it's estrogen. Okay. That's a big lifesaver. You'll be a hero there. Okay.
Oh, okay.
Keep that one in mind. Here are the blood levels again. I'll send you these if you don't have them. I'm not going to read them. These are the laboratory values that we look at. And again, the estradiol to progesterone ratio. We want that to be less than 250, and elevated estrogens. Like the books say, Dr. Gordon says greater than 100. We got him on coming up this Tuesday, by the way, on our webinar. Yeah, we're getting better. Yes.
Dr. Asher?
Dr. Gordon, Mark Gordon?
Oh, no, Eric Asher in England?
I haven't had him yet, so get me a contact. I'll try and get him. Elevated estrogens, again, 7-keto DHEA. This is just a chart of symptoms on the left of estrogen excesses, basically, and then you can see as the estrogen progesterone ratio increases, the symptoms get worse and worse. Okay, under 250, that's our goal. Alternatively, but early on we didn't get estrone levels, so what we did was we took progesterone, we multiplied it by 1,000 to even out the units, and divided by estradiol. You can do it with saliva or serum. This is the serum level. Anything under 100 is estrogen dominant. Anything over 500 is progesterone dominant. So if you don't have an estrone level, you can do it with estradiol and progesterone. The other one's a little bit more accurate. So here's Marie again. So again, her estrone is 40. Her estrone is 42. Her estradiol is less than 0.5. I'll usually take 0.1 as a number just to give us a number. So 42.1 divided by 0.1 or you can take 0.2, and that would be 420. That's how we get that. Okay. Basically, the estradiol is 0. If you want to take this as 0.1, it would be 0.1 over 0.1. So that would be what 1. So again, the PE ratio will reflect the same. Okay, so that's how we get that. Here's Julie. Here's hers. So estrone. Add these two together, divide it by 0.06, and then we got your 7,750. The PE ratio, remember, we want that to be between 100 and 500. So you're going to take our progesterone, we're going to multiply that by 1,000, and then divide it by the estradiol. And then we get that 0.22. Okay. Here we are again. Do it that way. You know what? I think I was copying this somewhere and it got copied again. So these are the same slides. Get through them. So I got the same. Oh, you know what? I'm going backwards. That's why. And what Aunt Audrey, you know what Aunt Audrey would say, right? You dumb boy, you.
Dr. Clearfield, I have just want to let you know, I have a meeting that starts at 10 o'clock. Will your presentation be done prior to 10, do you think?
I'm not really sure. If you want to stop here and we can pick it up next time.
Be okay if we did that? Because I don't want to miss anything here that you're teaching.
Okay. All right. So we're going to pick it up next time. We'll talk about Julie's labs, and then we'll talk about how to treat it. Okay. So we can do that next time.
Yes, sir. Thank you.
Okay. All right. You're going to be around next week? It was Thanksgiving weekend.
Yes, sir. I'll be here.
Okay. All right. Say hello to your lovely bride. You guys got to get out here. So, or I got to come to Texas to redo the face because it should be done. We got Daxified now. You know, it's supposed to last 6 months. I don't know if it does, but it's supposed to. That's what it's advertised as.
Dr. Clearfield, she has given me strict orders to contact you. We're going to see my parents in December. You know, and she wants me to do her Botox again, you know, under direct supervision, you know, from you. And so I told her I would find out where to get, you know, the Botox from, and then I would just, you know, do it, you know, on Zoom.
Okay. Oh, you want to do it that way? Sure. I mean, if you want, I can get Christy to send you to, you know, where we get it from, or we can get it for you, either or.
Okay.
Okay.
Take another, you know, trip up there. That would be amazing. It would be awesome.
Yeah. Okay. So hang on. Let us. We're gonna sign off for now as far as